All right, we're back up. Well, first of all, thank you again for the opportunity. You know, I've been performing laser vitreolysis or laser floater removal for about 4 years, about 1,600 cases. And I think there's a misperception. There's I think a pushback and some skepticism about this procedure. And for good reason. There's a lack of information, a lack of understanding of what we're doing now with modern laser floater removal. Here's my financial disclosures. Here's from Wisconsin. I'm going to fast forward through all this. There's still a lack of understanding of how much of an impact floaters have on patients' daily functioning. There's actually a journal article in an American Journal of Ophthalmology back in 2011 that asked patients, what are you willing to risk to get rid of your disease state? And patients were willing to risk more to get rid of their floaters than diabetes, high blood pressure, asymptomatic HIV, and others. And about 7 out of 10 people will have a symptomatic floater in their life, and 30% will be chronic, affecting their daily functioning. But why has there been so much skepticism? Why has this not taken off in the past? The reason why is traditional YAG lasers are only meant for and designed to help understand the posterior capsule as well as the iris. It's not meant to view the middle or posterior vitreous. So we had a lack of ability to visualize those floaters, but also understand spatial context. Where is the floater in relation to the retina? Where is the floater in relation to the lens? That is a key problem for historical lasers. And so if you look at the lasers, the illumination, the light source, the illumination, and the laser are not on the same optical pathway. So when you're trying to look at a capsule, that's fine. But if you want to look down below at a floater, if the illumination source and the laser are not on the optical system, same optical path, you can't visualize, let alone treat these floaters. So with the new laser that has come out and a lens that we designed, there are actually ability now to fire the laser with the visualization, the illumination in the laser all in the same optical pathway. So now the laser mirror goes out of the way as you fire. This allows for us to visualize much better in the middle of the vitreous, posterior vitreous as well. And here's an example. We can fire this laser both with the laser being coaxial or on axis. We can also fire the laser going oblique. That's important because it gives us a different visualization. When it's coaxial, we get a red reflex. When we move it oblique, we lose the red reflex and visualize more anterior structures. Now I'm going to explain how that works. When you're coaxial or on axis, we can see very well where the floater is in relation to where the retina. If the retina is in focus and the floater is also in focus, it's too close. So a pearl, if the floater is in focus and the retina is out of focus, we are safe enough to perform the procedure. Now, if it's an anterior floater, let's say it's right by the posterior capsule, then we can go oblique or off axis. We get a different visualization system. We lose the red glow, but then we can give ourselves spatial context of what's happening right behind the posterior capsule. Here's a couple of videos demonstrating this important feature. So if you look here, here's a floater. Now this floater is in a more posterior vitreous. I see the floater, but then I can also go
down
posteriorly and see where the retina is. So
gorgeous.
There's a floater.
Here we go.
Right there. Okay, now I can see. Let me rewind it here.
It's far enough away, so we're good.
Okay. So
can you do me a favor? Can you look more to your left for me?
To find out where the retina is.
There you go.
So there's a floater.
That's better.
The floater's there.
Have a
The
good
retina's in
central
focus. There's
view.
a floater. So I can go back and forth, making
retina.
sure the retina is not in focus. That's how I know
And
where I am to
down.
give ourselves spatial context.
That's perfect.
Now when we fire, we're
gorgeous.
firing at
Here we
millijoules
go.
of approximately 5, 6, 7, 8 millijoules, which is a lot higher than standard YAG capsulotomies. Now, we're causing optical breakdown. We are actually causing a vaporization of the floaters. So you break it, vaporize, break it, vaporize. So we're using 150, 200, 250 shots, which is a lot more than people are used to with the standard YAG laser. And I'll talk about why, from a safety perspective, this is okay. I'm just going to fast forward here. Let's say you have a floater right behind the posterior capsule. The key to this laser is understanding spatial context. So here I am firing in a phakic patient. I have to know where is the posterior capsule so I know I will not hit the capsule. So what I can do in just a few minutes, I can go ahead and move the laser oblique or off axis. Now I can see the floater. I lose the red reflex, but now I can see where the floater is. But I can also look at where the capsule. I can pull anteriorly, say there's a posterior capsule, there's a floater. Now I know spatial context. I know I'm far enough away from the posterior capsule to actually fire safely and not hit the posterior capsule. That is the key element for a safe performance, because if you do not have spatial context, you can't safely perform the procedure. You can also titrate the illumination with this laser. You can also go ahead and say, okay, I'm in the middle of the vitreous, not quite anterior, not quite far posteriorly. If I go too far oblique, I can't see the floater. Now, if I move straight coaxial, there's too much of a red glow. So I can titrate how much of that red reflex I want by moving about 10 to 15 degrees off axis. And I lose the red reflex, but I have enough of the coaxial illumination to know where the retina is. So here I can maximize my visualization to understand where I am and give myself that spatial context. Without this technology, historically, we didn't have that ability to know where we are in the middle of the vitreous. So I can always know, and safety-wise, understand where I am. And when we fire, it's a very visually rewarding procedure. We'll show you a couple of videos here in just a second. And you are actually not just breaking apart. There's actually plasma reaction. The second feature that's really important of why this is a new technology is the ability to actually understand what's happening to the laser energy when it's fired into the vitreous. What they did with this laser is they truncated the Gaussian curve. Instead of a large rise and fall, it's a sharper rise and fall. That decreases the amount of dispersion of energy. But more importantly, when you fire any YAG laser into the vitreous, you see a small acoustic wave of energy around it, and then the energy comes back towards the source. The distance between here and here is called the convergence zone. The key feature and the most important property of laser energy is when you fire a laser into the vitreous, it's a non-linear relationship. So the amount of energy on the laser does not correspond linearly to how much energy is dissipated in the eye. So at 1 millijoules, you're only about 110 microns. If you increase it to 10 millijoules, you only go to 210 microns. It's not a 10-fold increase in dispersion of energy. That is why we can fire at higher millijoules and not be worried as much about dispersion of energy or collateral damage. Here's an example of an ultrasound we did. We held an ultrasound temporally while we were firing the laser. What I want you to see, you're going to see some lines. Those lines are not laser energy, that's artifact. I want you to focus on how little movement is occurring behind the plasma reaction. So here's an example, firing at 8 millijoules, very little movement of vitreous is occurring behind that mass in the center of the vitreous. So it's a very quiet procedure, not a lot of dispersion of energy in the eye. So we published a paper, and we actually presented at ASCRS back in 2016, looking at 362 patients. And we asked them, yes or no, did it make a difference? We have about 93% of patients who are satisfied. More importantly, after one session, about 70% improvement. After multiple sessions, about a 90% improvement. The most important issue is when you have a Weiss ring, very easy to treat, very easy to identify, and correlate with patient symptoms. Multiple amorphous clouds can sometimes take multiple sessions, and you have to educate the patients ahead of time. They may take 3 sessions to get rid of these floaters. Now, we had an average of about 6 to 7 millijoules to actually complete this procedure. That's what changes the paradigm, is understanding we can go to higher levels to cause optical breakdown. From a safety perspective, people want to know, how safe is it? We have not seen a detachment yet out of 1,600 cases I've done now. No vitreous hemorrhage, no vitritis, AC reaction. What I have seen is one retina I hit because I did not follow my rule of thumb. If the floater is in focus and retina is also in focus, you do not fire. I'll show you that in just a second. Also, we hit 2 lenses, and that was because when it came out, we did not realize you have to go off or oblique with your slit lamp to understand where the posterior capsule is. Once you learn that, we have not hit any lenses. We've had a few pressure spikes. If it's a pseudophakic post-YAG patient and the floater is right behind the lens, we have seen, if you do too many shots at one time, a pressure spike. But overall, from an inflammation standpoint of view, in a retina, it is a very safe procedure. One thing I'm very excited about is the use of aberrometry to finally objectively demonstrate the improvement we're seeing in patients' quality of vision. So using the eye trace, which is an aberrometer that shines light into the vitreous, into the retina, and looks how it falls on the retina, also has a topographer to separate cornea versus internal optics. And here's an example of a patient we did this on. So here's a video showing you the type of floater it was, a large amorphous cloud in the middle of the vitreous. So now we use this laser to fire and remove this large clump. So the question is, did it do anything to the quality of the optics of the eye? So here's the eye trace, and the eye trace has a cornea, E, gives you representation E, and internal optics. The lower this number, the less quality of internal optics in the total. It gives you higher order aberrations as well as refraction. This is preoperatively a DLI of 3.79. Now, post-op day 1, undilated, again, it's a phakic patient, improved to 10. Now, you look at the modular transfer function, pre and post, we improved the contrast sensitivity significantly, and the refraction did not change. So we're seeing across the board, here's another case, a large amorphous cloud, pre and post, improving in their quality of vision, the MTF curve, pre and post. So we're seeing on multiple patients an improvement in not just subjective improvement, but more of a quality of vision improvement. So we're seeing now that patients are coming in with improvement in how they can see, they can read, they can drive. Now, I want to show you a video of when I did hit the retina. And this is, the laser is very safe, but it's you as a physician that have to know when to fire. There's a linear rope-like floater that was in more of the nasal retina. Now, I should have listened to my own advice and not fired because the retina is way too in focus. But I said, let me try to be a hero, which I would suggest you never be a hero in any new procedure. I started firing, and I fired in just a second. And I see here, just a second, I see a small little white spot. Ended up being a choroidal hemorrhage. Luckily, it went away after a few months. Patient had no problems with visual acuity, and it was a nasal retina. So everything was fine. But that is a case where I should not have fired because the floater was too close to the retina. Here are the two cases where I hit the lens in the periphery there, which the patient's doing fine 4 years later. This is a patient here on the right where I ended up having to do a cataract surgery and remove the lens, put a sulcus lens because the capsule was torn. These are the only two lenses I've hit in 1,600 cases. So if anyone's interested in doing this procedure, the key is being able to understand where the floater is, judge the size. If patients have symptoms, and you can see the floater in the middle of the vitreous away from the lens or the posterior or the retina, it is a very safe procedure, understanding some of those basic principles. So if you're starting out, I always recommend starting out with a pseudophakic patient with a Weiss ring, somewhere you can easily correspond or correlate the patient's subjective issues with your findings. Make sure it's not too dense, it's in the middle of the vitreous. And if it's a new PVD, wait for about 4 to 6 months, recheck, let them neuroadapt, also check the retina for any small tears or holes as well. For the sake of time, I'm going to fast forward through some of this as well. But what's also nice about the ability for coaxial illumination is that we can also use this coaxial illumination to understand and use it for capsulotomies. But unfortunately, the video is not playing. But the key for me is understanding those basic principles. If you have any questions or any concerns, my email address, oops, those are my kids. My email address is here. You can always email me. I have multiple videos online understanding how to use this procedure and how to use the different technologies. Thank you very much.
Good evening, everybody. I'd like to just a quick introduction to my co-instructor. My name is Dr. Unnikrishnan. I'm from Toronto, and we're just dealing with this course on anti-VEGF, not the routine indications and all those things, but how anti-VEGF can be dealt with in this new era where we have a lot of considerations. My co-instructors are Dr. Mahesh from the Giriraj Institute, Cochin, Dr. Gopalas Pillai from Cochin, Dr. Rupa Kanti Bishwas from Calcutta, and Dr. Preetham Samant from Mumbai. So we're going to cover a few topics, and the first topic is going to be one of the burning topics as to the heading is how to legally and ethically, the safe way to use Avastin. Dr. Mahesh, please.
I will start with a case. A 64-year-old gentleman presented with defective vision of left eye of 2 weeks duration. He was a hypertensive, visual acuity was 6/36, immature cataract, applanation tension normal, and this was the fundus. And you can see a supratemporal branch retinal vein occlusion, fluorescein angiogram, OCT showed significant macular edema. So he was given intravitreal Avastin 1.25 milligram in the theater. 4 days later, he presented with severe vision loss. Best corrected visual acuity was hand movements, anterior segment showed cells and flare, and there was no hypopyon, pressure was normal, and this was the fundus picture. Very hazily seen the disc. So we immediately gave intravitreal vancomycin and ceftazidime, and AC tap was done for grams, KOH, but it was all negative. He improved gradually. With one more injection, he cleared. 1 month later, clearing. Macular edema had gone. 2 months later, he improved, and there was no recurrence, luckily. This was one of the 6 cases we got over 5 days 2 years back. They were given along with 11 others from the same bottle, and our technique was more or less described by VRSA and AIOS, OT fractionation into multiple tuberculin syringes, and it was kept in an autoclave tray, and it was retrieved daily. Same technique we have been using for the past many years, and one of the cases which presented little late required vitrectomy and intravitreal antibiotic. All others improved with intravitreal antibiotic only. So we are all afraid of this condition of getting an end of in an Avastin case. So I'll come back to the title of my talk. It is how to create a legally and ethically safe environment for using Avastin. There are two terms in this. One is legal and other is ethical. Ethical is easy to speak. Towards the end I will tell. So I went through the literature. There was an article in the International Journal of Biological and Pharmaceutical Research by an Indian. It gives some definitions. Off-label or unlabeled or unapproved prescribing refers to prescribing a registered medicine for a use that is not included or disclaimed in the product information. Examples: use in a different indication, different age range, different dose or different route, as is in our case, and not approved by regulatory authorities. So this is in contrast to an unlicensed or unregistered medicine which have neither been evaluated nor approved for any indication. So this is not unregistered or unlicensed, it is off-label is unapproved, that's all. In oncology, pediatrics and geriatrics, and they cannot treat without off-label medicines. And some disease, off-label medicine, like small non-cell carcinoma, lung carcinoma and cystic fibrosis, off-label treatment is the only treatment available in the world. So in a study conducted in 2006, as much as 21% of doctors' prescriptions are off-label. So this is regarding the word off-label. Now, what are the issues and challenges of off-label drug use? One is lack of adequate database, which is not there in our case. Day before yesterday, I searched Avastin retinal diseases. There are 2,676 articles. So we have a very strong database of evidence regarding the use of Avastin. There are some other issues like reimbursement, which we cannot settle now. And the article goes on to tell that off-label prescription is legal for clinicians, but it is their responsibility to evaluate the evidence supporting the off-label drug use and inform the patient written consent regarding off-label use, its benefits, cost, risk, and alternative treatments. So this legal term is also a little tricky because this is regarding American laws. In Indian laws, it is still in the gray area because drug control will not accept it as a legal thing. So in India, it is a gray zone. And the other point is, although it is legal for clinicians to use drugs off-label, it is illegal for the pharmaceutical manufacturers to promote their approved drug for unapproved conditions. That is why Roche is always ditching the doctors. Now, regarding the informed consent, all of you might have seen this, the VRSI AIOS informed consent for Avastin use, which is a beautiful informed consent with all loopholes sealed. You can download it from the website. And VRSI has explained some guidelines like purchase from authorized Roche distributors and don't go for cheaper Avastin by spurious drug makers. Verify the seal and expiry date. And there is something called Kessler code in the Avastin bottle which was there initially, then they removed, it may be coming again. So that can be verified to see the authenticity of the drug. And cold chain has to be monitored, maintained for Avastin use, 2 to 8 degree. Many times one bottle you can keep in one pocket and then go to different hospitals and give. The cold chain is broken. So ideally that should not be done. The cold chain is very important, especially in transport of the drug. Now coming to the fractionation, what VRSI has suggested is it should be done in a OT with preferably laminar flow hood and a scrubbed person, just like a cataract surgery. And the unscrubbed person will hold the bottle with a 20-gauge syringe with a single prick, take 0.2 ml in a tuberculin syringe, and one syringe has to be sent for a bacterial culture and sensitivity. And after 48 hours, after getting the culture report, this can be released. And this has to be stored in an autoclave tray at 2 to 8 degree in a sterile pouches or EO-sterilized packets in the fridge. Should not be frozen. And maximum we have to use it within 2 weeks, otherwise discard it. So this is what they suggest regarding fractionation. The procedure, all of you know how to give safe Avastin. Roll out any infection by slit lamp pre-injection. Pre-injection antibiotics is not mandatory. It has to be done in an OT or a sterile area under topical anesthesia. 5% povidone drops has to be put. 10% povidone iodine lid scrub has to be given. Always use speculum. Do not touch the lashes. Within 3 days, they are suggesting review, but what in our experience, about 14, 15 endos in the last 8 years, all of them presented 4th or 5th day. So next day if you see, you may be seeing it is normal, but they may come after a few days. But explain to the patient any loss of vision or pain, they have to report immediately. And diabetes control also, it is a gray area. Usually less than 200 only we all inject. Points to remember, the presentation is usually blurring and not a pain in early cases, since it starts from behind. The patient comes with, unlike a cataract surgery where pain is the most important thing. And first day it may be normal, but 3rd or 4th day they can have a problem, since the inoculum is very small. Immediate management gives good results. And beware of spurious Avastin, already mentioned. Regarding ethics, ethics is defined as moral principles that govern the practice of medicine. Millions of people who can't afford costly injections may go blind, and Avastin is a boon. So if used in the correct indications, not guided for financial gains only, the use of Avastin by us definitely justifies ethics. Thank you for the kind attention.
Our next speaker is Professor Dr. Gopal Pillai. Dr. Gopal Pillai is a renowned retinal surgeon and head of department at Amrita Institute of Medical Sciences, Kochi. And he's going to tell us how to handle patient expectations and outcomes after repeated injections of anti-VEGFs in DME. Dr. Gopal.
Thank you very much, Preetham. So we have heard about ethics and how off-label medicine is used. Now it is about patient expectation, handling the patient. So we know the science, we know that injections are needed, long-term injections are needed, but the patient doesn't know it when they come to us. And the patient definitely feels that after 1 or 2 or 3 injections, or after the first 3 months or 6 months, everything will be cured. And that is where there is an expectation versus reality mismatch. So what did we, in this particular presentation, we'll look through what did we learn new about DME, and what are the key treatment options that we have, what are the pitfalls usually that we see in our practice, how should the initial dialogue with the patient be, and how to keep him motivated on a long period, and some illustrative cases and conclusion. So we know that good tight metabolic control is very important, so we require to motivate the patients for that. Laser, anti-VEGFs and steroids are the 3 arrows that we have to actually kill this diabetic macular edema. And in rare situations, you may require vitreous surgery for tractional DME, etc. So laser photocoagulation as standard treatment, it helps to slow fluid, it will basically stabilize vision. Even now in circinate exudates away from the fovea, you could still do laser, and you can see that the 4th picture, it's like clean, that CSME has gone away. This was an age-old focal leak, getting a focal laser, or a diffuse leak, getting a diffuse laser, and a fluorescent angiogram. This was in the pre-OCT era. What are the limitations? It does not eliminate the possibility of further vision loss. Further vision loss keeps on happening. And improvement in visual acuity were very uncommon. And sometimes there could be some complications. There could be heavy burn, maybe 5 or 7 years down the line. You may see that the laser burn has enlarged hugely, etc. And come to this type of cases, laser definitely is not a first role. So we have a lot of intravitreal injections, triamcinolone, bevacizumab, ranibizumab, dexamethasone, aflibercept, fluocinolone. So all these are available. And these are some of the trials which all these drugs have gone through: Resolve, Restore, Bolt, and then the Protocol I of the DRCR.net, the MEAD, the Placid for the Ozurdex, and Protocol T, which introduced the ILIA to us. So DRCR.net Protocol I is the most commonly cited thing. You could see that these were the 4 arms. These had laser in 2 types, either a deferred laser or a prompt laser, along with different injections, that is ranibizumab as well as triamcinolone. You could see that the ranibizumab arms are the worms which are lying up front here, and the triamcinolone arm has gone below, and also the control arm has gone below. Then came monotherapy, whether ranibizumab by itself can actually help it. So RISE and RIDE trials showed that there was a significant improvement in vision. Up to 30% of patients had, 50% of the patients had 2 to 3 line improvement in vision. And similarly, such responses were actually obtained in steroids also, MEAD study and Placid study. And again, 15-letter increase in about 20% of people were there. But here, there was more incidence of cataract, and some very small percentage of people requiring trabeculectomy, and some more people requiring anti-glaucoma medications. And FAME study basically looked at a long-acting implant in diabetic macular edema, which is recalcitrant. It was quite good. So with this preamble, this is the protocol T, which showed that when visual acuity was less than 20 by 50 or worse, then actually in the first year there was a significant difference between aflibercept and ranibizumab, aflibercept performing better, but in the second year that difference became statistically insignificant. So what are the pitfalls in practice that we have? One and most important, most common, poor diabetic control. Most people come to us, we keep on injecting, patient is getting treated elsewhere for diabetes, and that takes a parallel course, this takes a parallel course. Finally, he is not under control, diabetic edema keeps on recurring. Economics of injections, very important thing. Avastin has to a certain extent reduced that economic burden, but even then, even Avastin, many people are very difficult for them to inject on a monthly fashion. Many people will not have every month they have to come. They won't have bystanders to come every month, and there is a mental fatigue that develops in a patient after probably 6 months or 1 year to say that, you know, it's not going to get all right, so let's stop treating, or they may go to some alternate treatment, Ayurveda, Homeo, etc. And there are a lot of coexisting illnesses which can actually worsen diabetic macular edema and also prevent the patient from coming to us, like diabetic foot infections, stroke, heart attack, renal failure, etc. So the initial dialogue with the patient is very, 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 very important. That dialogue should have, first and foremost, the patient needs to be educated. Not only the patient, the family needs to be educated. What would happen if I treat? What would happen if I not treat? That distinction has to be spelt out to the patient. There are DME booklets available, which I generally give it to the patient's family and ask them to read it outside and then come back inside for further counseling and explain about long-term treatment. Many people I've heard telling the patient that, you know, 3 injections we will do and then it will be all right. And then they come for a second opinion after 3 months when the doctor says, yeah, a 4th injection is required. And then they will be very, very unhappy and unsatisfied because initially they were not told that this requires a long-term treatment. Multi-pronged approach, including multiple injections, laser. At some point of time you may require a vitrectomy. At some point of time you may require much more diabetic control, lipid lowering. All this is required, and long-term prognosis with and without treatment has to be understood by the patient. I have devised a new thing called diabetic retinopathy risk calculator, where 100 images, graded images from less severe to more severe are put in, and there is a software algorithm in which you add hemoglobin A1C, lipid profile, renal failure, all these things, and if you enter here with his fundus picture, the fundus picture which will be 10 years down the line if he doesn't have treatment will come out, which will basically frighten the patient. So frightening is a little bit important at that point of level. It's not about frightening, it's about education. So these points have to be controlled, diabetic control, hypertension control, stopping smoking, regular eye checkups, handy PowerPoint precipitate can be helped, socioeconomic counseling, and good repo. How to keep him motivated? OCT follow-ups can show decrease of edema, which will keep him motivated for the first 3-4 months. But after that, it is actually the vision which is more important. So if vision starts improving, then he gets a little motivation for the first 6 months to 9 months. And then you have to somehow try to reduce the frequency of follow-up by either phone follow-up or reducing the number of injections, changing to long-acting injections, considering laser at the macula, etc. So some of the illustrative cases, here is one patient who had very mild macular edema, very mild. You can see that intravitreal Avastin 1 was given, 2 was given, repeat OCT and 1 month, 6 months, no edema, very good, no problems. These are early CSMEs, are the patients who will do well with monotherapy, but they get a false sense of security that if you give 2 injections, everything will be all right. And next time when they come back, they will be much worse than when you first treated them. So these patients need to be educated on this follow-up. Next case, he had a little of cataract as well as diabetic macular edema, mild macular edema. Intravitreal Avastin was given 2, 3, and vision improved to 6/9. There was a cataract surgery which was done, and then after some time he required another injection. So in the presence of cataract surgery, you may require to modify. Pre-cataract surgery you may require to give, or post-cataract surgery you may have to educate the patient that he may require more treatment like this. This is a long-term follow-up of another patient who had macular edema. You could see that multiple anti-VEGF injections. You could see that after more advanced diabetic macular edema, you require multiple injections. This particular patient required a lot of injections. DRCR.net said a median of 9 injections in the first year, 4 in the second year, and 2 in the third year. This is again another patient in whom after 19 Avastins, 4 Lucentis, 3 Ozurdex, vision improvement from 5/60 to 6/12 parts over 8 years was there. And if one anti-VEGF fails, you generally move to the other. Then you may require a dexamethasone long-acting implant. Maybe you require to add laser multiple times, and that is how we do. Whenever there are bilateral edemas, you basically try to treat. Some countries do simultaneous injection in both eyes, but generally we do not support that. And if we are maintaining them on monthly injections, then it becomes difficult for the patient for follow-up. Every 2 weeks he requires to come. So I generally put them on Ozurdex in one side and anti-VEGF injections, one of the anti-VEGF injections on the other side, which will take care of a lot of problems. Now this is a patient who got punctured multiple times with diabetic foot, renal failure worsening, stroke, etc. When you have a recent stroke or heart attack, again, anti-VEGF is a no-no. And if this guy develops a glaucoma at some point of time, steroid is a no-no. So the basic point in treatment is continuous follow-ups. And many a time the patients cannot maintain these continuous follow-ups, and education is the key there. Now this patient had bilateral edema, ischemia, and this was the both eyes. So you had to treat one eye with steroid eye plan because the pseudophakic eye planned with steroid, and the other eye planned with anti-VEGF. You could see that edema reduced, but vision did not improve beyond 6/36. And that is a low motivating factor for this patient. And after that's the point when I decided that we'll do a cataract surgery on that eye. There was a little bit of improvement to 6/24, and that is how that patient went on. So sometimes you may require to have epiretinal membrane removal. Like in this particular case, there is a OCT which showed us that you required a surgery at that point of time, and this is an epiretinal membrane which we thought posterior hyaloid, in fact, which we removed out of that macula to reduce that edema. And in some other cases, there may be a vitreomacular traction in which you may require to do an internal limiting membrane peeling to remove the whole this thing. So finally, what does the patient want to know? One, will I improve in vision? Yes, you will. And you have to drive home the point that only if you continuously treat, you will improve in vision, otherwise you will deteriorate. So the chances of deterioration, we should basically tell them from the studies, how many injections are needed. Generally, getting the blood sugars under control, the number of injections reduce. And probably DRCR protocol I is a good guide to tell the patient that first year they had 9 injections, but we will try to reduce it somehow. But the second year and third year, if your sugars are maintained very well, and if you treat your macula dry, then probably the number of injections will reduce. Which injection to take requires a little more dialogue with the patient regarding economics as well as his previous history. Are there any side effects? You should be open to all side effects. I had a stroke doctor or a heart attack doctor, requires a special this thing. If I am not improving, why so? We should look at ischemia again. To conclude, intravitreal injections now form the mainstay of DME management. Multiple injections are the cornerstone. Systemic control is very important, and may need to change the drug, and dialogue with the patient at each visit is a very important thing. Thank you very much.
Thank you, Dr. Gopal. The last 2 talks covered the practical aspects and some of the issues that are covered. Do we have any comments or questions about the last 2 talks? Anybody would like to make a comment or a question? Please.
I'm Dr. Goswami from Central AIOC2017, Odisha. I'm looking after the medical retina aspects of there. Now, I had a very similar situation where a patient had a CVA in the last 3 months and also had pre-existing glaucoma. Now, how do you take care of these patients, and what would you prefer out of them, steroids or anti-VEGF?
How severe is the diabetic macular edema is one question which I will ask. What is the other eye situation? Is it early macular edema, late macular edema? We also, from the trials, we have found out that if you delay our institution of treatment by, let's say, 6 months or 1 year, the catch-up, really almost many of the patients will catch up with time. So even if we are delaying, like stroke in 3 months, I would not want to treat him. And pre-existing glaucoma, generally we would be adventurous if you are putting a steroid in. So I would think I will wait, And if that is the only eye, that eye suddenly edema occurred, vision dropped down below 6/60, he is the only earning member of the family. Those things you have to weigh in mind before you do the risk-benefit analysis. Pardon me, sir?
I said you'll have to take subjective matters into consideration. In that case, would you prefer anti-VEGF? Will you take the risk of giving anti-VEGF?
In a diabetic macular edema, I would not usually take a risk. In a one-eyed neovascular glaucoma, I may take that risk.
You would prefer giving a steroid if you don't have an option. You have a patient like that, one-eyed, he's about to lose vision.
We could, in diabetic macular edema, it doesn't just lose vision, right? So it will reduce. It is moderate visual loss, which is more commonly seen. So, yeah.
Yeah, I would just like to add a point. In this area, sometimes we just forget that we can do laser in some of these patients.
That's exactly what I wanted.
So there are some patients where you can go look at it again, where both your hands are tied. You cannot do an anti-VEGF immediately. You cannot do a steroid immediately. You can actually look whether there are focal areas. Do not be too aggressive with the treatment. Start from the periphery. Try to come in slowly, and you can buy some time. I think the American Cardiology Association says 4 months. Yeah. Yeah. Okay. The nice point made. Thank you. I'd like to, if there are no more questions, I'd like to introduce our next speaker, Dr. Preetham, who is an eminent vitreoretinal surgeon from Mumbai, working at the associate professor at the JJ Hospital. And from the practical aspects, we're going to look at the multiple options we have. A new option is aflibercept, and we really would like to know whether it gives us advantage over the current stock of anti-VEGFs. Dr. Preetham.
Thank you, Dr. Unni. Aflibercept, or Eylea as we know it, is the new kid on the block. And with new anti-VEGFs, there is always a lot of expectations, but there is also a lot of concern about whether it's really efficacious. Is it better than the existing anti-VEGFs? Is it safe enough as compared to the previous anti-VEGFs? So we'll try to look at all the evidence gathered about aflibercept up till now, and let's see whether this particular new kid on the block is really worth it. So the mechanism of aflibercept works by a similar mechanism as ranibizumab and bevacizumab. It's essentially an anti-VEGF. But instead of being an antibody to the VEGF molecule, it's a fusion protein consisting of portions of the receptors of the VEGF molecule, thereby binding and blocking the VEGF itself. So that is a unique aspect of aflibercept. Now, as we know, the indications of anti-VEGF, the bulk of indications of anti-VEGFs in any medical retina practice is essentially macular degeneration, wet AMD, RVOs, and diabetic macular edema. So let's deal with only these three main points today, and let's see what the verdict, if we can come to a verdict as far as aflibercept is concerned. So there have been a lot of studies. There have been studies done on AMD, RVO, diabetic macular edema, myopic CNVM. I've tried to be as objective as possible, because you can't obviously in 10-12 minutes finish off all the studies looking at all the aspects. So let's look at wet AMD first. So there is this VIEW trial which has head-to-head compared aflibercept with ranibizumab. It has compared all the 3 doses of aflibercept with ranibizumab, and the verdict. So it seems it is as efficacious as ranibizumab, all the 3 doses, in giving the kind of visual gain that all the anti-VEGFs give normally in wet AMD. So aflibercept is as good as ranibizumab and not really that better. Okay, and this particular effect continues over the long term, over 4 years. So there is a good, robust 4-year data from this study which shows that it is as efficacious. But as always, when you look at certain sub-analysis, when you look at depth into a particular study, then you see actually the differences. So when they looked at certain atypical types of CNVMs, those with PEDs and intraretinal cysts, these are really the atypical CNVMs. There they saw some difference where they found out that aflibercept seemed to be taking a slight edge above ranibizumab, although it was not that statistically significant, but it did take a slight edge, mind you, in these cases of PED and intraretinal cysts. This is the data of intraretinal cysts. Again, aflibercept slightly edging ranibizumab. Of course, IPCV is now, it's a major chunk of macular degeneration cases, and it is really, really tough to treat these cases like this one here, where you saw there's a PCV with a CNVM and subretinal hemorrhage in the inferior macula, treated, scarred, resolved, and 1 year later it comes up somewhere here, superior to the, in the superior part of the macula. So this is typically how these PCV cases behave, very tough to treat. Now, we had this study not so far away, Everest study, which compared, which actually basically it addressed one question: is PDT relevant in PCV in today's anti-VEGF era? And what it told us, simple, that PDT, only PDT did not give that much visual gain. It was very important to have anti-VEGF in your treatment for PCV to get the visual gain. But when it came to polyp regression, it was PDT which was scoring. PDT was scoring over just anti-VEGF when it came to polyp regression. So the bottom line, which was understood, was that in PCV, the combination treatment was important: PDT to ablate, to regress the polyp, and anti-VEGF for visual gain and to curb the CNVM. Okay, so this was what we believed till aflibercept came on the scene. Now, with aflibercept, we have the PLANET study. Now, the PLANET study essentially compared aflibercept with PDT and aflibercept. And what it found out, it was addressing the question, is only aflibercept as good as PDT with aflibercept? And it was pretty surprising to find out that both the results matched. And when they looked at the polyp regression, that also was pretty surprising. Almost more than 80% of patients had no active polyps at the end of 1 year. And more than a third of patients experienced complete polyp regression. More than a third of patients. If you look back at Everest, it was only about 15% patients at polyp regression. Here we are talking about more than a third patients. So this is something like a dramatic result which aflibercept seems to be offering. But I'm sure the jury is still out because, mind you, we have only 1 year data. In PCV, like I told you, we need to look at 2 years, 3 years, 4 years, how the disease is behaving with only anti-VEGF. So this was about PCV. Now let's look at myopic CNVM. What does aflibercept offer in myopic CNVM? So here we have aflibercept with sham treatment versus sham treatment, and definitely there is aflibercept seems to offer a good 13.5 letter improvement as compared to sham treatment. Now we were using ranibizumab so far. So let's look back at the Radiance trial. So not so bad. Ranibizumab gave 14 letters in the Radiance trial in myopic CNVM, and aflibercept is giving us about 13-14 letters. So I would say here the verdict is balanced, equally balanced. It's not really better, but it's equally good as ranibizumab. Now let's look at vein occlusions. Now vein occlusions, there have been 3 studies. There is Vibrant in BRVO and these 2 studies for CRVO. They have studied aflibercept. And what have they found? Now in the early, that is as early as 6 months, there is a fantastic result. There is gain of about 17 to 18 letters across all the 3 trials. That means in BRVO as is CRVO. So that's a fantastic result, and this seems to extend well up to 1 year. You can see at the end of 1 year also there is about 17 letter gain. Let's compare it to what we know. What we know is the Bravo and Cruise. In Bravo, ranibizumab gave us same, about 16 to 18 letters gain. In Cruise, ranibizumab in CRVO gave us about 12 to 14 letters. So maybe in BRVO it is in par. In CRVO there is just that 2 to 3 letter difference. Maybe aflibercept is slightly better, maybe not statistically significantly better. So again, here it is as good. That another point here is we are always concerned to differentiate whether a CRVO is ischemic or non-ischemic. Would it work? Would aflibercept work equally good in a non-ischemic and a ischemic CRVO? So here also they looked at subgroup analysis, and they found out this dotted line is the ischemic CRVOs, and the hard line is the non-ischemic, and you can see it is doing equally well in both these studies. It is doing equally well both in ischemic as well as non-ischemic CRVOs. The last thing I'm going to touch upon is DME. That's the bulk of the treatment. Now we already have Dr. Gopal showing us some data from the protocol T. Now the efficacy of aflibercept was tested in these 2 trials, the Vivid and Vista, and they found it was very effective in having visual gain, 12 letters and 10 letters here in both these trials as compared to sham treatment. But it was this, I just put 2 cases to show here. This is a case where I've used Lucentis, and you can see how the diabetic macula improves both on OCT and angiography. I have put in some rescue laser over here at the end of 6 months. This was Lucentis, and this is one case which I have done so far with Eylea, and you can see it works equally well, as you can see over here, with the edema improving. So again, which is better among these two? So I think this is one trial which has addressed this. The protocol T of DRCR net compared head on these two. In fact, they compared all the three agents, both Avastin, ranibizumab, and Eylea. And what was the verdict here? So the verdict was, at the end of 2 years, all seem to be doing quite okay. The bevacizumab, you can see, is lagging little behind Eylea and ranibizumab. But mind you, aflibercept and ranibizumab are absolutely on level. But, I always believe when the pharma does the trial, they're always looking at something which will prove their product better. So when they do the subgroup analysis, that is where they find the difference. So they try to look at those cases where the starting vision, where the vision at the beginning was below 20/50. Now in these cases where the vision was poor to start with, you can see aflibercept has an edge, although not statistically significant, it has an edge above ranibizumab. So probably with the really bad diabetic edemas, aflibercept is working better. This is the OCT outcomes. Again, OCT outcomes, the reduction of macular edema is equally good with these two. Bevacizumab lagging slightly behind. What was important to understand here is the frequency of injections. If you're giving something much more expensive, can you give lesser injections? That is always a thought which is foremost in our mind. Well, that is not the case. You can see across all three groups, all three required 9 injections in the first year and 5 injections in the second year. So in a total of 14 injections in 2 years. So by shifting over to an expensive agent, you're not reducing the number of injections. That is quite obvious here. But one important aspect which came to the foremost was the need for laser. Now this was statistically significant. The need for laser with aflibercept is much less as compared to both these two previous anti-VEGFs. And this need in the second year also was less. So probably here it is helping. It is saving the ablation which is required, the rescue laser which might be required in DME. The last point I'm going to touch upon is the safety issue, the safety profile of these anti-VEGFs, and I just discovered this particular article as late as 2017 in the Retina journal, where they have looked at the pharmacokinetics and pharmacodynamics of all these three agents. And this is what they had to show us. These are the levels of anti-VEGFs after injection in the blood. These are the levels of the normal VEGF being suppressed, the normal VEGF in the blood which should not be suppressed being suppressed. You see the highest is bevacizumab, aflibercept is in between, and the lowest is ranibizumab. So apparently ranibizumab seems to be safest. When it comes to suppressing the normal VEGF, surprisingly, it is aflibercept which is at the top, then bevacizumab, and then again ranibizumab is not suppressing the normal VEGF so much. Okay, so this is what the pharmacodynamics are showing. But this is my last slide. If you look at the protocol D, this gave something which was really surprising. It told us that when it came to safety profile, a greater number of non-fatal strokes and vascular deaths was seen in the ranibizumab group, and this was, mind you, statistically significant than the aflibercept group. So this is a little confusing here. One which is safer is that particular group is causing more problems. So again here I think the jury is out. So in summary, aflibercept I would say definitely is as good as the existing anti-VEGFs. The question whether it is better, probably in atypical wet AMDs where PEDs and IPCV it is acting maybe better. Relaxing doses, because some of the studies have shown that an 8-weekly dose is as good as a 4-weekly dose of ranibizumab, especially in those atypical wet AMD and PCV cases. Maybe it decreases the need for laser in DME. That is what the protocol T showed. And is it cost effective? This is the biggest question, because mind you, it is 3 times more expensive than ranibizumab and probably 10 times more expensive than bevacizumab. So that is always going to remain a big question mark. Thank you.
Thank you, Dr. Preetham. I invite Dr. Unnikrishnan Nair, who is the director of Chaitanya China Hospitals in Kerala. He is a well-known vitreoretinal surgeon. And while he is getting ready with the talk, any questions to Dr. Preetham regarding aflibercept? Okay, Dr. Unnikrishnan.
Okay, good afternoon, everybody. So, we're talking about anti-VEGF. So, I'm just going to skip and say, what are the possible uses of when we can use steroids and replace anti-VEGF at least sometime during the treatment. Now we are into a mode where there's a drive to dry, which means that we don't stop till we find the retina is flat and dry. Whether we're not really convinced whether it is required yet, but this is what we aim to. So I'd like to start by saying that we're going to go at this in sequences of 3 about steroids, the use of steroids. So the first thing is that it has been considered that the anti-VEGF is a holy grail of treatment of DME management. And of that holy grail, the DRCR network is a shrine of knowledge. And the mantra which is associated with steroids is that steroids equals complications. So this is what has been driven into our minds. And we have so many studies that have been reiterated that tell us that anti-VEGF are wonderful for DME treatment. So the thoughts that have come out of that, one, steroids are not as efficacious or safe as anti-VEGF. Steroids are tried and are currently out of favor primarily. Steroids are used mainly when anti-VEGF is contraindicated. These are the 3 thoughts that most people have in their mind. Now let's go to the 3 important trials that led us to this thinking, the ETDRS, the TDMO, and the DRCR network. We love jumping from trials when it's easy to understand the conclusion. So the ETDRS told us, yes, let's do laser and we'll prevent moderate visual loss in 50%. So all of us do laser a lot. The TDMO trial or the triamcinolone trial told us that triamcinolone is better than laser up to 2 years, but at 2 years, laser and triamcinolone didn't make a difference. And then the DRCR network said that photocoagulation was as effective and had fewer side effects of triamcinolone, and triamcinolone fell out of favor after the protocol B. And then the protocol I came and said that anti-VEGF is all you require for treatment of DME, nothing else is required. So over time, the trials gave us different thought processes, and we end up now thinking that anti-VEGF monotherapy is the key. So what are the 3 things that we have? There are fallacies of the trial, the fallouts, and the fatalities. The fallacy of the trial, one is that photocoagulation was found to be more effective, but the amount of triamcinolone used in the trial was 4 in a period of 36 months, which we know is a very, very small amount. That is 4 injections of IVTA in 4 years was compared to laser. You cannot compare things like that. But more importantly, when the visual acuity was low, giving 4 mg of IVTA had the best results among comparing with laser or 2 mg or 1 mg, which meant that in the subgroup where the visual acuity was poor, triamcinolone did work. So there is a subgroup that says that steroids were better in diabetic macular edema. And this is interesting. The exclusion criteria of the DRCR network was the inclusion criteria of the study called TDMO. And both of them gave contradictory results. One said triamcinolone was good, one said triamcinolone was bad, because one's exclusion criteria was the other's inclusion criteria. So you have a contradictory result there. So the summary of the thing was that 4 mg of IVTA was useful in patients with severe visual loss. So steroids did score a point. The fallout was that of these studies was that the result is that anti-VEGF was supposed to be the treatment for DME, which is center involving. IVTA was supposed to be okay for pseudophakic patients. Steroids was a choice in patients previously treated with anti-VEGF, laser, and vitrectomy with poor results. They said you could use steroids. But however, when the 5-year results came, something called the legacy effect was thought of. That is, treating a patient well in the first year would give you protection in the 2nd, 3rd, and the 4th, and the 5th year, evidently. So again, we have shifted more towards anti-VEGF and away from steroids. So the fatalities of these were the Retisert, which was stopped halfway through, the Ivation, which never picked up, and the FAME study, which was terminated. All these are steroid studies. But generally, when you put aside all these studies and pause to think, we have to think in sequence. The first studies told us that laser prevented but didn't improve. Intravitreal therapy improved vision. We believe that anti-VEGF is a preferred choice, but we feel that you can get an equivalent effect of steroids in pseudophakics and a superior effect with steroids when the starting vision was poorer. So I just want to take you through the pathogenetic mechanisms. Here you can see 3 pathogenetic mechanisms, all of which are VEGF mediated. The universal truth is that everything is not just VEGF mediated. Some of the mechanisms in diabetic macular edema are inflammatory mediated. And here you can see all the inflammatory mediators there, which tell us that DME is a multifactorial pathogenesis. The second point I'd like to make is that VEGF is not one. There is VEGF pleomorphism, which means that genetically all of us don't have the same type of VEGF in our body. There are different types of VEGF which have different receptors, and VEGF, anti-VEGF suppression does not depress VEGF uniformly. The third point I'd like to make is that inflammation is a primary role inside DME. So you have anti-VEGF mediated mechanisms, you have non-anti-VEGF mediated mechanisms, and you have got pleomorphism, which tells us suppressing anti-VEGF doesn't work equally for all people. Therefore, this is an important fallout of the study. Suboptimal response to anti-VEGF is there in a subset of people, and the belief in certain studies is it contributes for more than 50% of failure of anti-VEGF while treating DME. So I would like to just go to this thing. There are three new paradigms of when you're thinking of steroids. One, you have to identify and talk about something called chronic DME. Two, you have to identify what do you mean by suboptimal response, and those patients might respond better to steroids. And three, what are the structural changes that happen that could give you a poor outcome? So the first thing is defining what do you mean by refractory CME. Different studies said different things. Some said 3 injections, some said 3 months, some said 6 months of anti-VEGF. If it doesn't respond, you call it chronic DME. But the current the suggestion is that if you have no change within 3 injections, you could call it chronic DME. Therefore, there is now something called chronic DME and non-chronic, not acute, non-chronic DME. It is a structural definition of the macular changes. Non-chronic DME is supposed to be VEGF mediated, and chronic DME is supposed to be inflammatory mediated. So what happens? In the initial phases of disease, you have a VEGF mediated disease. You have leakage, you have inflammation happening. But as the retina gets older, there are structural changes. Your RP is weaker. So it's a self-propagating disease that happens, which may not be responding to VEGF all the time. Therefore, this is a point of time where VEGF may fail, anti-VEGF may fail, and where your steroids may start to work more and more. So just to put it in structure, chronologically you could have initially a VEGF-mediated disease, an inflammatory-mediated disease as the disease becomes older and older, and finally a structural changes mediate the non-responsive aspects. This is a study which said that non-chronic DME responded to intermittent treatment with laser and intravitreal therapy, but when the disease became chronic, it responded better to continuous low-dose corticosteroids better. That point in favor. Chronic DME may respond to intravitreal depot preparations better. The next is classifying the response of type of treatment to anti-VEGF, which will tell you who is going to respond to steroids better. There are 4 responses that have been identified. One is the early and consistent response. The patient responds early to anti-VEGF. Second is the patient responds early, but each injection is an inconsistent response. The third is it's a slow response, and each injection doesn't produce a consistent, it's a variable response. And the last group is the non-responder patients. And it is found out that about 25% of your anti-VEGF patients that you give for DME are actually non-responders. There is another type of incomplete response, and that is the lack of follow-up and the lack of coming to the, adhering to a protocol, either monthly PRN or treat and extend. So non-compliance is a reason for incomplete response. So the last thing is that the structural changes, I'm just going to touch upon this. There are a few structural changes that give prognostication value. One is the drill, the disorganized retinal inner layers, and the other is the ellipsoid and the outer retinal integrity. So patients with these 2 changes have seemingly poorer response to anti-VEGF. So these are some of all of these have been taken care of, and I'm just going to give the selective incorporation, what we can divide into 3, a primary, secondary, and a circumstantial. The primary, the DRCI network said we could give it in pseudophakic patients primarily. In close proximity to a planned cataract surgery, you could give it. That was a Mead study recommendation. A primary, it can be thought in a vitrectomized eye where the vitreous is not there, a sink for giving the anti-VEGF. The duration of anti-VEGF would be less in a vitrectomized eye. That was a Champlain study. And again, to prevent hard X-ray migration of the fovea, there are 2 studies about that. One was a Vivodex study comparing bevacizumab and Ozurdex, and another study by Larson et al. So when you have a hard exudation which is threatening the fovea, a steroid might be better than an anti-VEGF. The secondary is that when you see non-response, you give anti-VEGF, again 3, then you have to switch over. The sustained release or Ozurdex might be a better response. Features of chronic edema: thicker CMTs at presentation, large cystic spaces of the fovea, ellipsoid zone loss, and ELM disruption may be features. Structural changes that can let you think of going in for a steroid rather than an anti-VEGF initially. And the third is circumstantial changes. When you have a higher risk of a thromboembolic risk, bilateral patients where it is difficult to give monthly injections frequently, you can stabilize one eye on Ozurdex and the other eye you can give bevacizumab. When there is poor patient follow-up, another thing is that increasing macular ischemia and increasing foveal atrophy could be an indication where you move away from anti-VEGF and give steroids. So the complications of steroids are three. One is the IOP, the cataract, and the third is the bad publicity. We've gone through all the IOP concerns. I'm not just going to touch them. One important thing is that the future implant, the Iluvien implant, comes with a label. It says that you are allowed to give Iluvien only when you do a steroid trial. That is, you give a topical drop for the patient for 4 weeks to prove a steroid response. Then only are you allowed to give Iluvien. The next complication would be the cataract, the economic burden. See, whatever the strategy for anti-VEGF, the patient ends up coming to the hospital 9 to 12 times a year. So this is going to be a major thing that we're going to tackle in future, just to make sure that the economic burden of the patient reduces. So what do we have to do? We may have to relearn things. We have to relearn the significance of chronic edema, the structural clues in the retina to tell us to use steroids, and identifying and documenting the four natural responses to anti-VEGF. We may have to reorient ourselves and try to find out the eyes where we may introduce steroids earlier than just keep on giving the patient anti-VEGF. And we may have to reuse. That is, what I say reuse is that personalized medicine. Each patient you don't label as anti-VEGF or steroids. You might have to mix and match all these things. As the good doctor said, some patients you might still have to go back and give a good laser treatment also. So a simple take-home message, which is not very scientific. 3 months of steroids after 3 injections of anti-VEGF, if more than 300 microns, works in about a third of the patients for a third of the price. So that is why I say that 3 is a magical number. Thank you.
Since the time is running, any questions? We will go to the last talk by Rupakanti Biswas. After that, we will take few questions.
Good afternoon, and thank you. Thank you for avoiding temptation of listening so much of vibrant music outside and being here at this evening hour. Thank you, Dr. Unni, for inviting me in your course. And this is actually, the last thing in the basket. This is last but not the least. This is something like, I would like to compare Krishna in Mahabharata. So, when the Arjun was and Pandavas all there doing all the works, and when they are in trouble and is being called, Krishna is being called. So probably PDT is having the similar kind of role in today's Mahabharata of medical retina. I don't have any financial interest directly or indirectly for any product what I will be mentioning here. So what we need to know is exactly what is the aim of the treatment. When you do treatment in case of AMD, by saying AMD, I mean it is neovascular AMD, and what is mechanism of PDT, and how it is different from anti-VEGF, and a little bit of epidemiology of AMD. So initially the treatment of AMD, neovascular AMD, was preventing severe vision loss, and from there we are moving towards the visual gain. Now with this process, the whole anti-VEGF has started its course. Now the secondary gain, by this way the secondary gain, which is still we are looking, is the closure of the new vessels and preventing the recurrences. So by this way, actually you are going towards the primary aim. So though it is the secondary aim, but these are the primary things which can give you the visual gain. Just for the non-retina person, just to mention, for the PDT, it's the vertiporphin dye which we inject into the vein, and it gets concentrated in the new vessels. With the direct laser activation, the nascent oxygen is being released, and which actually causes endothelial damage, and by there inflammatory vaso occlusion occurs. So this is how it is different from anti-VEGF. Whatever has been till now has been described is anti-VEGF is causing the regression, and this is occlusion. So whenever you have a blood vessels having a lumen, having a polyp, whatever you are, whenever there is an exudation, it comes from the lumen. So the unwanted blood vessels which you need for the completely occlude to prevent recurrence and preserve your vision. I was looking for the literature, and there are multiple studies, multiple series has shown that there are almost on an average 40% of the exudative AMD is having a underlying PCV, which has been diagnosed later, which has been treated as a AMD, neovascular AMD for quite long time, and then ultimately it was diagnosed to have. So if you retrospectively think, actually the 40% of the patient which was needing PDT from since the day one itself, if you can diagnose early. So I will come, what is the role of, already Dr. Samant has mentioned about the role of PDT and aflibercept in PCV. I'll come into that. But whom to suspect, like who are the cases where you should actually look for? In fact, at present scenario, it is, we are always thinking of doing all AMD cases, neovascular AMD cases, as a routinely ICG to get incorporated into it to rule out the PCV, especially in Indian Asian scenario. But particularly those who are having the poor response to monotherapy, more exudation or hemorrhage compared to the size of the lesion, or there is an orangish lesion, subretinal lesion is present, and the other eye, history of other eye having the poor response to anti-VEGF therapy. And these are the cases ICG should be done to rule out polyp. And choroidal thickness and OCT angiography, these are little relatively newer advances in imaging modalities. But yes, these are the two things which can clearly guide you about the presence of PCV. Now, this is very important at this stage to find out whether it is actually you are dealing with neovascular AMD or it is some AMD-like diseases. So that's what my stress will be there. So if you can differentiate from the initial days itself, your line of management will be different, your unnecessary injection needed, everything will be much more less. So here it, even in the Everest study shows clearly that after 6 months there was almost near about in combination with anti-VEGF or without anti-VEGF PDT is more than 70 to 80% is having the complete regression of the polyp, which is a significant amount number compared to the only monotherapy of ranibizumab, which is 28-29%. Even the Everest 2, which has not yet published, that also shows there is a significant difference. The second one, significant difference of 69 and 34% of complete polyp regression. This is a case which was diagnosed as neovascular AMD and having a classic CNVM here, type 2 CNVM, which is leaking profusely at the late phases, was treated with monotherapy, ranibizumab 3 injection, and then followed by a monthly follow-up. But again in 5th month, it recurred, 4th injection, 7th month, again this picture. So really you go back and see, this is exactly where there is a localized polyp with that whole area. Can I have the pointer? The whole area is having the branching vascular network. So this patient was, PDT was done and it has regressed completely. This is a slightly of different thing. The literature says that yes, there is a discrete role of PDT in polyps and pachychoroid diseases, but yes, there may be a variation of the response depending upon the genetic mutation condition. But yes, there are good responses in all the cases. There may be slightly more or less. So the other scenario, like when the monotherapy, there is recurrence after monotherapy, and another scenario, which again, due to short of time, we cannot cover, is the retinal angiomatous proliferance. Though the primary treatment modality is still anti-VEGF, but in advanced cases, we do have to do PDT as a combination therapy. So to summarize the whole thing, combination therapy probably would be the best choice of treatment, especially in this kind of AMD-like diseases, exudative AMD with underlying PCV, or maybe recurrence with monotherapy, non-responding advanced RAP lesions, and it may have a variable response. But which is more clear from all the studies is that even in those cases where PDT is being used, the need for anti-VEGF therapy is much less compared to the other control group. Thank you. Thank you so much.
Thank you, Dr. Rupak. Do you have any questions or comments?
I have a question for Dr. Rupak. In PCV also, do you use low fluence PDT or you use full fluence PDT? What is your choice?
Low fluence.
Always low fluence?
Yeah.
PCV. PCV, there is a lot of edema. We are using high fluence regularly. Yes, sir, we are always using low fluence.
Yes, but again, it depends upon if there is a significant amount of the edema, then I will not prefer of doing the PDT as a...
Then reduce the edema, then do PDT.
So just a general word out for us who are treating anti-VEGF, a lot of people have to reconsider that PDT is an important key, and those who don't have, some people don't have access to ICG, it is still a good idea to find a person in your city who does ICG and get ICG done, because PDT is a reality. I mean, you cannot ignore that you have to do PDT in patients.
Does PDT cause damage to photoreceptors? Like anti-VEGF doesn't damage at all, so does PDT cause some damage?
And that is the whole concept of the reduced fluence that has come out. There are two points. One is the reduced fluence, and two is whenever you are treating the fovea, you have to be careful. And three, the area. It is preferable, generally preferable not to treat more than 3,000 microns at one sitting. That the energy delivery to an area of 3,000 microns. These are just rough guides, but usually when you follow these areas, you don't get. See, the concept was choroidal infarctions, which were used to happen high when we used to treat with high fluence PDTs. Now the concept has come to low fluence or half dose PDT, where you use only 3 mg per 3 milligrams instead of the 6 mg. So you use less amount of energy delivery to the choroidal choroidal layers.
And
CSR, if the leak is sub-foveal, can we use PDT in that?
Sorry, CSR?
For CSR?
Yeah, if it is chronic CSR and leak is sub-foveal.
Yeah. Actually, we are using low fluence PDT for subfoveal leak CSR, and we have done fundus fluorescence and now doing multifocal ERG after 6 months, 1 year. We are not able to find any damage due to PDT. You cannot say, because the chronic CSR itself can cause reduction in the foveal peak in multifocal ERG. So as such, it is giving good results in subfoveal leaks.
One thing is using low fluence PDT. The Japanese have also, they suggest doing half dose PDT also. So they have given good results by halving the dose of the vortiporfin and doing that kind of a sort of a sub-threshold PDT in CSR. Answering your previous question about PDT does cause, in some patients of wet AMD, it does cause a transient reduction in vision.
Yes.
So that concern is always there. And to counter that, there have been some people like Spade and all who have, what they do is they do PDT and then give an injection of anti-VEGF combined with DEXA, what they call as triple therapy. So to counter the inflammatory effect of PDT.
And in cases of wet AMD, can we have complete resolution with limited number of PDTs so that we may not require anti-VEGF? Is it so?
See, that was with the previous, the VIP studies and all. When you had small membranes before the anti-VEGF era, you had resolution. You had resolution of membranes with PDTs. It's just that we were not happy with the visual recovery. So you can have a complete resolution of a CNVM, a classic CNVM, small classic CNVMs, used to do well with PDTs. Now with the additional knowledge that you can reduce the dose or reduce the power of the PDT, maybe we haven't looked at it that much. But having said that, anti-VEGF may be the one that causes the least structural damage than the PDT. So in all cases of classic, you would prefer to probably go with anti-VEGF. Okay. Yeah.
What's your take on peripapillary CNVs? Would you rather go for combo therapy or?
That would depend upon the location of the peripapillary CNVM. So you have got type 1 and type 2 can happen there. Obviously, for your pre-RP, you think of it as a different way than your sub-RP CNVMs, isn't it? For your sub-RP CNVMs, your anti-VEGF may not be as effective, and that is when sometimes you add.
Usually, peripapillary CNVM is due to peripapillary polyps. That pre-RP is quite rare. That is classic CNVM in the angioid streaks. So in angiostics, currently monotherapy is the thing, anti-VEGF. But in the other one, you can easily do thermal laser to the polyp along with anti-VEGF combination. It works, really works, the peripapillary polyps especially. Rather than giving, the previous session, the PDT was done very close to the disc. But there are cases reported where after PDT hitting the disc, AON, acute vision loss, there are cases reported. I will be little hesitant to do very close to the disc.
And with this newer machine, you have the very small size PDT also. So you can very precisely do the PDT in multiple spots also. So that is also possible.
That you can reduce the spot size anyway. Yeah.
So if that's the end of the questions, I'd like to just introduce our keynote address speaker, Dr. Polymer Prasad, who will be talking to us about something that we have been discussing, the excessive load on anti-VEGF clinics and the role of nurse specialists and non-medical injectors. Dr. Polymer.
Good evening, and you got that on. Thanks the IOC to inviting me on to do this. When asked to give a topic, I thought let me choose something different. I come from UK, and this is what I'll take on. Yeah, thank you. That's the one. Next one. This one. So I've heard all the sessions so far, and whereas here we have issues in India about what drug to choose because primarily of the financial constraints. We've got. I got it. Yeah, thank you. So firstly, I don't have any financial or proprietary interest. We do have training sessions sponsored by Bayer. So we've gone to the patient outcomes in any of these conditions, beginning with AMD, which is one of the other speakers alluded to. That's the largest burden. So if you have to have a good response, then you've got to go to the patient pathway, make sure the patient accesses services easily, quickly, early diagnosis, assessment and treatment, clinical efficiency, good communication. All that we seem to have cracked. Therapy, we've got safe therapy, we've got proven therapy, we've got some guidelines in the UK, we have to follow certain guidelines, and all that is fine. However, it still is expensive. And when we talk about expense, we're not only talking about expense of the drug itself, but also we are talking about expense of delivery of the service, particularly in getting the staff. And we are continuously forced to relook at our services to make it not only clinically effective, but also what is known as cost effective. So with that in mind, we started relooking at the pathway. See, traditionally, what we have conventional pathway is we've got the triaging. Let's go back, sorry. Is there a pointer here? Yeah. So we've got the triaging of the patients when they're referred in with suspected wet AMD. Let's start with wet AMD. Diagnosis. All this was being done by doctors, as was being done here. Loading injections, depending on what drug you're using. And then back to the monitoring, again, doctors. And then re-injection as and when necessary. So as it starts becoming more and more, and the number of doctors are very finite, we have very strict guidelines on how many doctors you can recruit and how many trainees. So then we started thinking outside the box. So the first thing to do is transfer stable patients onto virtual clinics and do this. These clinics are being done by optometrists, who are opticians, working to a certain guideline or protocol. So they would look at these patients and based on need for re-injection, back to re-injection, but again, it's the doctors. With all these new research coming on, we began with AMD as PRN protocol, but then we know that we need to do more and more injections, or almost monthly injections, to get the best result. So exponentially, there's been an increase in the number of injections. From 510, way back in 2010, over 5 years, it's gone 300%. At the same time, we haven't had doctors increasing by 300%. So then we started introducing these. The nurse injectors. The Royal College of Ophthalmologists dictates our standards, and they acknowledge that we have issues with capacity, particularly with staffing levels, and they stipulated that it's safe to use other injectors. Now, this is a key slide here, because if you're going to involve anybody else, we've got to keep all these in mind. The patient is under the care of a named consultant. He should be fully trained, should be aware not only of the technique, but also the rationale for treatment. it shouldn't be done in isolation. So this is done when there's other doctors present. Continuous audit to make sure they're safe. The hospital trust, now the trust I mean the business end of the side, and that is particularly because of this indemnity, that is medical insurance. As doctors, we are covered by medical insurance. Some of it is borne by the hospital trust. But these people who are giving, we have to make sure they belong to an association which actually will support them if they have legal problems. And if they're going to take consent, the General Medical Council tells you that they should be fully trained on that. And finally, doctors in training must not be affected because somebody else is doing the injections. So with this in mind, we've had a few studies already, firstly from Moorfields. I won't go through all of that, but showing that it is safe practice. We've had other things outside Moorfields. So what we did was, 2 years ago, we started this. Now this time we got an orthoptist who's quite young, keen, active, and he's quite cheeky. And the big question was, would you let this guy, he plays rugby, he's 6'4", massive chap, would you let this guy close to your eye with a needle? Firstly, we have to take support from other consultants, colleagues in management, as I said. We have to make a business case to show that it is financially viable. We have to have clear guidelines and protocols, and we have to have a training program. Financially, it was a no-brainer, as we call it, because you see in the traditional model, we had about 3,000 patients going through, whereas with increased capacity with these injectors, it went up to 3,600, which means you need less sessions because, again, we worked only fixed sessions. Anything extra has to be paid extra. So the trust or the hospital is saving money. And also, other than AMD, we had non-AMD patients. And these patients were being injected in theater, displacing cataracts. So again, there's a financial benefit to bring them back into clean room injectors. And that was again shown here from 3 times or 5 times rise in the number of non-AMD. So this is how we go about doing it. We've made a business case, then we go for safety, and that's called clinical governance, where we lay down a complete, what is called a standard operating protocol. I've highlighted all that we need to look into. This is the program. I'm sorry for the small print, but basically what we say is we've got somebody, we have one training day where we go through the whole, the question of how to inject, etc., etc. Then they observe 20 patients, then they prepare 20 patients, and they inject 100 patients under supervision. It's only at the end of that they get signed off. So here's pig's eyes. We get pig's eyes with the lid in. Warrington is fortunate enough to have our own wet lab. So we got wet lab, and this is what we do. So 1 day training, and then 20, 100. End result, fully trained, audited, brilliant satisfaction. Patients are over the moon. And the biggest thing to us definitely is, particularly the non-AMD, we now find that we can run a one-stop clinic where we can see a patient, they go and get injected, and if you want to see the fellow eye on a loading dose, we can bring them back and see them in the clinic. So it's worked really well, and also it's going to influence probably our treatment. You know, there are basically 3 kinds of treatment protocol or posology. There's a fixed regime where you've got to have monitor every month. We got the PRN where you don't know, you see whether to treat to target, etc. But with something like this, where I have a fixed injector, I think this is what we're going to do. Treat and extend is going to be the way of the future probably, because we'll be booking these patients to definitive injection lists. So we've got 3 injectors who've done really well, and at the moment, as I said, hark back to non-AMD, that's had the biggest impact. More than 1,000 injections. Each of them have done 1,000 injections over 12 months. Excellent results. And I think that's the way of the future, and this is what we're going ahead in the UK. 2 things we have not done at the moment. They only do anti-VEGF injections, including Avastin, which, mind you, is off-license, off-label, but informed consent is done by the doctors. But the ones they do not do at the moment is the steroids. Neither do they do the Ozurdex nor the Iluvian. And we've got enough references here. So just a touch, it's a little, I've come from an oblique angle. I know it's not pertinent as yet. When I've said that I'm going to give this talk, this morning I was told that I'll finish off by being crucified by the doctors here because, it's all being done by doctors. But I think it just shows you, if you're going to run a program where you're going to involve other, what you call allied health professionals, it is possible, and this is the way to go. Thank you very much.
Thank you so much for introducing a different perspective and probably a different concept. And it's to be seen how well it's going to be taken in this part of the world. But anyway, could be in the future. Yeah, it's interesting. Yeah, thank you. Thank you so much. So thank you for attending our symposium, and hope it was useful for you. Thank you.